joining us for our 9th Southern Africa Regional Eco Session. We want to welcome our colleagues from Mozambique, Botswana, Lesotho, the Kingdom of Eswatini, Mozambique, and Malawi. Just to mention, last week we discussed vaccines and we had a presentation from Malawi and Zambia. So this is a follow-up requested session to discuss adverse events following vaccinations. We want to give special thanks to Team Eswatini for agreeing to present again this week because they are quite advanced in their vaccination campaign. I hope Mr. Simaleni has already joined us. Tolokwane, Toli, are you there?
Good morning. Good afternoon. Yes, I'm here. Thank you very much.
Okay, so Tolokwane is a surveillance officer from the expanded program of immunization in the Kingdom of Eswatini. His co-presenter is Dr. Agre Mwemba, who is a consultant physician. He's a nephrologist, and we ask in the infectious disease family, we call him an honorary member of our infectious disease family because we work with him in a lot of areas. We started with HIV and TB, and now he's a case management lead, clinical care specialist at Levi Mwanawasa Hospital, which was the first COVID-19 center that we opened in Zambia. Dr. Mwemba, Tolokwane, you are welcome. I am Sombo Foloshi here in the hub. Tolokwane, do you want me to share your slide deck or you will do it from your end?
Either way would work for me. I can share, you can share, we can decide which way. You can call me Toli, it works. Just call me Toli, it will work.
Okay, I will share the decks because I combined both of the presentations.
Okay.
Am I struggling? Sorry, I have to put people through this. I can see that we are joined by Dr. Sivile. We are joined by Dr. Matibula. You are all welcome. Dr. Matibula will soon be leading our advanced HIV echo, so we are excited. Toli, please go ahead.
Good afternoon once again, colleagues. It's a pleasure and honor to share this presentation in this forum. As it has already been mentioned, it's on adverse events following immunization from the Kingdom of Eswatini. Next slide, please. The outline in this presentation is going to be as follows. We are going to define adverse events associated with COVID-19 immunization, including cause-specific definitions. The second one will be to discuss classification of AEFIs into serious, cluster, and signal AEFIs. Third one will be to discuss AEFIs in the context of COVID-19 vaccine rollout. And lastly, we will discuss the AEFI surveillance cycle outlining detection, reporting, and responding to adverse events following immunization in the COVID-19 immunization. Next one, please. And here we have a poll question which requires us to look at fever and fatigue in the first 48 hours following receipt of COVID-19 vaccination. If they are considered as adverse events following immunization, are they supposed to be reported? And the responses are, it's two responses. It's either you need to look at it if it's true or false. And I think the next, okay.
Thank you very much, Toli. I'll let people vote. Is this statement true or false? fever and fatigue in the first 48 hours following receipt of the COVID-19 vaccine are considered as IAFIs and should be reported. Is this true or false? I hope, Toli, you can see the voting. I'll allow you
Yes, I can.
to answer this later. We'll give it 30 more seconds. Is this statement true? We've noticed a lot of fever and fatigue after vaccination. Should we bother to report them? Should we consider them as IAFI? Because a lot of us have had this and they go away. Should we be reporting or just never mind, it doesn't matter? So you have a very interesting voting pattern, which I 100% expected. We'll end that just now and share with the network. Toli will give us the answer later on at the end of the presentation when he has taught. We can see it was almost a half and half. Some people do not think that this is an IAFI, while others feel that a fever and fatigue should be reported after vaccination. Toli, please go ahead. Toli, please go ahead.
Okay, thank you. Thank you, I'm here. I had forgotten to unmute, sorry. I was saying colleagues should always keep in mind that we are talking in reference now to COVID-19 vaccination. And by definition here, since this is a new vaccine for us, we need all the data that we can get. So the definition here is any untoward medical event that follows immunization that does not necessarily have a causal relationship with the usage of the vaccine. The adverse event may be any unfavorable or unintended sign, abnormal laboratory finding, symptom, or disease. We also to say adverse event of special interest. That one is a predefined and medically significant event that has potential to be causally associated with a vaccine product that needs to be carefully monitored and confirmed by further specific studies. Next one.
So we have another poll question here. Toli, do you want to go through it?
Here we are saying state whether the following statement is true or false. Anxiety-related symptoms such as facial twitching after receiving COVID-19 can be considered an AFI, true or false?
Thank you very much. So is this statement true or false? Anxiety-related symptoms such as facial twitching after receiving the COVID-19 vaccine can be considered an IAFI. There's something wrong with the polls. The three that are at the bottom are not supposed to be there. Okay, so just vote true or false, thank you. Just ignore the things at the bottom. I think they were not loaded properly. State whether the following statement is true or false. Anxiety-related symptoms such as facial twitching, I'm sure we've seen a lot of these on social media, after receiving a COVID-19 can be considered an IAFI. Remember, when you say it's an IAFI, it means that you need to report it. Is this true or false? Interesting voting pattern. I am very excited. So as you can see, we have almost 40% thinking that feeling anxiety-related symptoms should be reported and the IAFIs, while some people feel that this is false. I'm sure Toli will elaborate later. Please go ahead.
Thank you. Would you be kind enough and remove the polling slide?
Sorry, we're having a delay because of internet. It will come soon. Has it gone? You can just close it from your end.
No, I've closed it on my end. Thank you very much. We are here saying that definition by cause, we look at basically 5 causes. The first one being coincidental events, where we say an AEFI that is caused by something other than the vaccine, immunization error or immunization anxiety. It's something that coincided with the event of inoculation, and then it produced a concern. And the second one for us is immunization anxiety-related reaction, which we are saying it's an AEFI arising from anxiety about the immunization. This one tend to be common where adults are concerned. You realize that when we are talking about infants, like a 6-week-old infant, the fact that when another one is being vaccinated and is crying won't necessarily affect the next one. But for adults, if one reacts in a particular manner, like that one that depicts fear or pain, and the rest of the team that is in line to vaccinate, they might have that kind of anxiety. And then the third one is immunization error-related reaction, where we say this one is caused by inappropriate vaccine handling, prescribing, or administration. That therefore is preventable. The fourth one is vaccine product-related reaction. This one is an AFI that is caused or precipitated by a vaccine due to one or more of the inherent properties of the vaccine product, whether the active component or one of the other components of the vaccine, like the adjuvant, preservative, or the stabilizer in the vaccine, can be the causative organism or material that will be saying now it's a vaccine product related reaction. And the last one here is the vaccine quality defect related reaction, where we say it's an AFI that is caused or precipitated by a vaccine due to one or more quality defects of the vaccine product. This may also include administration device as provided by the manufacturer. Next one. And then we go on to look at the classification of AEFIs, and the first one we're looking at serious AEFIs. We say a serious AEFI is an event that results in death, hospitalization, or prolongation of an existing hospitalization, or persistent or significant disability or incapacity. It may be congenital anomaly, which can be a birth defect or is life-threatening. That is a serious AEFI. And then there's also a cluster, classified as a cluster of AEFIs, whereby we say this is when 2 or more AEFIs related in time, place, and or by vaccine occur. Vaccine may refer to a certain batch, which at times is referred to a lot, a vaccine product from a certain manufacturer of vaccines protecting against certain strain of an infective agent. Also, a cluster may occur as a result of coincidental events, then they're also referred to as a cluster. And then the last one is signal. In this particular case, we say a signal is information that arises from one or multiple sources, which suggests a new potentially causal association or a new aspect of known association between an intervention and an event or set of related events, either adverse or beneficial, that is judged to be of sufficient likelihood to justify verification action. I always like to refer to, if you know there is this Rota vaccine where we know basically that it has that slim likelihood of causing interception in children. And when a child now starts producing after vaccination, after a period of time, the child started having projectile vomiters. For that, it actually gives us a justification to go in and investigate more. That is just as an example. Next one. Now we're looking at the adverse events for immunization surveillance cycle. The first one, we want to say it is very important for immunization programs in countries to establish surveillance system for AEFIs before vaccine rollout, because this will allow for systematic identification, notification, reporting, as well as investigation and data analysis, which will lead to causality assessment and feedback following and all AEFIs. Next one. This is just a summary of what happens, what is contained in the surveillance cycle, whereby we start with the detection of an AFI, and then we go on to notify and then report. At times, you find that detection, notification, and reporting will happen at the same point. And then it will be followed by investigation, which is also informed by the magnitude of the AFI. If it's an AFI that is not as severe or that requires special investigators, it will be investigated at the provincial or district level. And then there will be analysis, which then will feed into causality assessment as well as feedback to where the source of the AFI emanated. Next one. AFI detection and reporting, like I said earlier, some of these components will happen at the same place. Here, vaccine recipients, caregivers, and healthcare providers detect and report AFIs. I'll bring you into the Eswatini context. Individuals for COVID-19 will have, there is a toll-free hotline number where people, once they experience anything, there seems to be some static noise. Hello?
That's much better. I think it has gone now.
Oh, that's much better. I was just trying to bring it into our context, that in our context, we have a notification system in the IDNS, which is an electronic system, whereby an individual, because we're dealing with adults here for COVID-19 vaccination, an individual after vaccination will experience a deviation from being healthy to experiencing some symptoms. They then dial that hotline number. And that one, we interpret it as notifying the system. And then the system will capture whatever the person will report and guide on the next move for the patient. And then the IDNS will feed into the national level. That one we are saying is reporting in our context. And then the next element will follow. Often a passive surveillance system is used to detect and report, but sometimes an active surveillance system may be established through sentinel sites. Passive reporting involves reporting of AFIs through standard COVID-19 reporting forms and a phone call or application for serious events. Spontaneously reported AFIs should also be fed into the surveillance system. Next slide. We come to poll question 3. State whether the following statement is true or false. All AFIs must be investigated in detail. True or false?
Another lovely poll question with interesting votes. State whether this statement is true or false. All IAFIs must be investigated in detail. I think we heard how Tolly described the reporting process. So if somebody reports a fever, should you investigate? Should all IAFIs be investigated in details? Is this true or false?
Now I can open the...
Okay, we'll allow that for 30 seconds. This is extremely interesting. State whether this is true or false. We have 89 connections, 98, but we only have 57 votes. So most of us need to vote. State whether this statement is true or false. All IAFIs must be investigated in details. We'll end this poll. I'm sure we'll be told the answer eventually. Tolly, you can pick it up.
Thank you. Investigation of AFIs, depending on the country-specific surveillance structure, AFI's reporting form received at regional or district level should be assessed for seriousness before transmission to national or provincial level. No detailed investigation or causality assessment is required for minor or non-serious AFIs. Next one. Next slide, please. AFIs for further investigation will include, but not limited to, the following. It will be the ones that appear to be a serious event as defined by WHO of known or unknown cause. Will also be the ones that belongs to a cluster of AFIs, be it they are minor or serious, they will be investigated. The occurrence of events with an unexpected high rate or unusual severity, those that involves an increased number or rates of unknown cause, also those that are suspected immunization error. Investigation can be initiated at district, regional level, but for deaths or capacity is where capacity is not adequate, National AFI Committee, the EPI, or National Immunization Program should be involved. COVID-19 adverse events following immunization investigation form and WHO AFI investigation software must be used during investigation. Next slide. This is just a model of the IDNS structure. In our context, we start with what happens at facility level, where an AFI would be picked and it would be reduced into a reporting form, which in turn will be transmitted to regional level. And then at regional level, it is line listed and then also classified into minor or severe, which then informs the decision to investigate or not to investigate. Once that is done, it is also fed to national level, who in turn now will also look at them closely. For those that are considered as severe and are investigated properly, they will be fed into, or maybe they will be presented into the causality assessment forum, which is where the AEFI National Committee sits and look at these cases. But those that are minor or are considered as non-serious, they are not presented for causality assessment. And this at national level also, there is that line listing, which is also used now to report at the global forum, which goes into the global database. Thank you. Next slide. Analysis and causality assessment. Here, a systematic review and evaluation of existing information on AFIs after investigation to establish if there is a causal relationship between the event and the vaccine. This forum should be established either at national or provincial level prior to vaccine introduction. In the Eswatini context, because we've got only regions and then the national level, this committee is at national level, and this is where the activity occurs. Next slide. Analysis and causality assessment. Causality assessment has 4 steps as follows. Step 1, it looks at the eligibility. This step aims to determine if the AFI case satisfies the minimum criteria for causality assessment as outlined below. And then step 2 is the checklist. They go through the checklist which involves systematically reviewing of the relevant and available information to address potential or possible causal aspects of the AFI. This information involves the investigation notes as well as clinical documents that were availed to the team during the investigation. And then the third step is the algorithm. This step obtains a trend as to the causality with the information gathered in the checklist. And then the last one, which is the classification now, categorizes the AFI association to the vaccine or vaccination on the basis of the trend determined in the algorithm. Next slide. This one is also another summary of what happens in the surveillance cycle. That is a collection of information, data in particular, which feeds into the compiling of a report, as well as then going for classification, which goes on to hypothetically test the information in front of them in relation to the event and the vaccine, and then a conclusion is reached, which is basically a scientific conclusion using the information as well as the vaccine product information available. Next slide. Investigation should be timely, comprehensive, methodical. Where laboratory investigations are important, but should not be routine, they should be conducted if only indicated and necessary. Like in the case where it's recommended is where to secure investigation items like vaccines, syringes, it may be blood or other components, which will help in the proper, which has to be kept in proper condition in case they may be needed later for laboratory investigations. And autopsy investigations are often essential to exclude any coincidental causes of an AFI. This one actually talks to when there is a fatality, where then an autopsy would be needed to basically either rule out the final diagnosis when the person was still being attended to the facility. Next slide. This one now, I think is going to be talking to the poll questions, where we were looking at fever and fatigue. If they should be after immunization, if they should be reported as AFIs. And then the results, I'm not sure whether they are read from my end or from your end.
Those are read from your end. I'm just going to stop the poll, and you can see the voting pattern after what you have taught us. Then you can comment on the answer.
Oh, thank you very much. And yes, we say fever and fatigue should be viewed as an AFI and they should be reported as such. And the outcome here, we see that 58% of our voters felt the statement was true. And then unfortunately, 42% of the voters felt it was untrue. Like it was discussed earlier, that this is a new vaccine, and the definition, which is I always refer to as a layman's definition, is that any thing that will cause a concern following immunization is viewed as.
Go ahead.
I was saying any thing that will occur following immunization and causes a concern either to the recipient or the caregiver or a healthcare worker should be recorded as an adverse event following immunization. Hence, fever, fatigue, and a lot of these people for COVID-19 vaccination in our context in country, they've been reporting this as a concerns, and we have been taking them as AFIs, and some of them were duly investigated, but some of them you find that upon follow-up, the person is stable and it has resolved. Next slide. Hence, this statement is true.
Much, Tolly. Everybody here is just saying, oh my God, I didn't realize I had diaphy. So thank you for letting us know on that. So here is the second poll question. Please ignore the bottom four. Is this statement true or false? Anxiety-related symptoms such as facial twitching after receiving the COVID-19 vaccine can be considered an IAFI. Is this statement true or false? We personally, we had this case actually. We had somebody and they had facial twitching after the vaccine, like some days later. So we were wondering if it's an IAFI or not. Some interesting voting. I'll share the results soon. Okay, so those are the results. As I shared this, I've been joined in the hub by our team of doctors that has been handling our IAFIs here at UTH. So some of these scenarios we got from them.
Yes, thank you very much. We see it's very interesting, like you say, whereby anxiety-related symptoms after receiving a COVID-19 vaccine can be considered as an AFI, and the response is true. We look at our poll, we see 61% alluded to the fact that it is true, and then 36% felt or maybe believe it was false. And then for a strange reason, some felt it were all of the above, which we were guided not to consider. But to just talk to this one briefly is to say that we will recall that when we're discussing the different type of AFIs, we also touched on anxiety-related ones, whereby they are not necessarily caused by the vaccine itself, but it's caused by the awareness of the environment and the anticipation of what might happen. And they need to be investigated to exclude, because facial twitching at some point, you might think that it's just a reaction out of being scared or what, but if investigated, you might find that at times it would be associated. So it's best they are investigated and excluded as such, scientifically, not just the assumption. Thank you.
Thank you very much, Toli. We are now launching the third poll question. We ask the network to please vote with us. Can read it out.
We still waiting for
The question is this true or false? All adverse events following immunization must be investigated in detail. All adverse events following immunization must be investigated in detail. Is this true or false? We'll end the poll.
So can I go ahead?
Please.
This is also one interesting one. It's almost 50-50 because it's 51 versus 49%, with the 51% believing that it's true, and then the 49% believing it was false. All AFIs must be investigated in detail. It's false. Why? Because we mentioned when we were discussing AFI investigation and surveillance cycle was that those that are viewed as minor are not necessarily requiring investigation, a detailed investigation. Why? Because you find that for them to say they are minor, it's those that would actually even resolve without even revisiting a facility. So those that are like that are not necessarily requiring an investigation. Because if you are going to be investigating everything, like in this particular instance now, as we are approaching almost 200 in terms of cases of AFIs, are you going to keep up with those investigations? So hence, it is key that you investigate that require investigation, which are those that are considered as serious or severe. Thank you.
Toli, thank you very much. Really, thank you very much. Your presentation was short, but I learned a lot. So all those poll questions, they really brought out all that nuance that we may not know about IAFI. It looks very straightforward, but it's not. It's something that has to be studied. At this point, we will allow the network to go ahead with any questions that they may have. Just to check, I don't know if Dr. Dian Mansa has joined. We've just heard from the Kingdom of Eswatini that they've had 200 IAFIs reported so far. I don't know if we have representatives from Malawi, Mozambique, Botswana, Lesotho. How many IAFIs have we reported? Maybe we'll start with Zambia. I know we just started our vaccination campaign. Any IAFIs?
Excuse me?
Yes.
Yes, I'm not sure. My apologies if I was wrongly quoted. I said we are approaching, not necessarily 200.
Oh, okay. So you're almost
We
there.
are over 100. We are over 100 and counting though.
Oh, okay. Okay. Do we have any figures from Malawi on IAFIs? Because I know it's not very easy to do this, and as it was mentioned, we need to make sure our surveillance system for IAFI are strong before we actually start the immunization. I think there's a question from Justin Mirembe. Please go ahead, Justin. Kote, let's please unmute Justin. So there's a question here. Yes, Justin, please go ahead. Okay, we seem to have lost. Yes, please go ahead.
Hello, can you hear me?
Yes, Justine, I believe.
So, thank you for the presentation. So we were just wondering whether there are any adverse events of special interest as we start embarking on receiving different types of vaccines that countries should be monitoring, specifically any adverse events of special interest for the AstraZeneca versus J&J versus the Pfizer vaccines. Thank you.
Thank you, Justine. Tolly, did you hear that? Do you want to pick it up?
Yes, I got it. It's a good question, but colleagues, I also would like to keep reminding us that this is a new vaccine. Hence, as countries or as programs, we have the responsibility to feed in data that will inform the safety and none thereof of this vaccine. In our country, we've rolled out AstraZeneca vaccine, and the biggest challenge that we having as a country is the capacity of our health system, in that you realize that some other tests need to be done, but they are not available in country. Like for instance, I'll take for instance, or not necessarily not available in country, but they're not easily available. We find that maybe they are there in the private sector, which I'm not aware. Like there is this test, which is the dimer test, because we know there is a great concern globally for blood clotting disorders associated with AstraZeneca, and in recent data, we've also had association with Pfizer as well. But what I want to bring the attention is that you find that in a facility setting where there is that presentation of someone who some of these lab tests and some of these symptoms that are presented will lead to a clinician maybe thinking of pulmonary emboli, but will not necessarily have the precise tests to prove that. Like in our context, we also lack the services of we lack autopsy services, that if in the event that one maybe can maybe eventually die out of a suspected emboli, it cannot be proven beyond reasonable doubt that yes, indeed, it was a blood clot. At what level? Was it at a heart level? Was it at the brain? Was it anywhere? So those are the things that are bringing in challenges in the surveillance system, because when now this case, that case is taken in for causality assessment, whatever conclusion will be reached will be considered as a probable conclusion as opposed to a conclusive conclusion, because all what was needed to be done to conclusively say, yes, it was this, were not necessarily conducted. I'm not sure whether I'm responding appropriately to this question.
I think you have responded very well, Tolly. Justine, just hang in there. The next presentation actually will deal with your question a bit more in detail, but Tolly, thank you very much. Just a question, is it in order for us to consider the clots from the AZ and J&J as IASIS, adverse events of significant interest? Yeah, you're on mute.
Having been raised globally, because we know it has been a concern that has been raised by not only in country or maybe in Africa, but even in other countries in Europe, in America, it was raised. So for us, for me, not necessarily for us, but for me, it's an adverse event of special interest, because it will seek to feed into the information data sheet for the vaccine going forward. Because like I said earlier, as countries, we owe it to ourselves to do thorough investigations and run the necessary tests to feed into the global database for informing the safety and none thereof of these vaccines.
Thank you so much, Tolly. I really wish we had more time, because this group of doctors here, we've actually been seeing quite a number of patients, and we've been able to do these fancy tests, but Dr. Mwemba will go into that. There's a request from Tafa Adwa. If you can again explain the classification of adverse events in terms of it being classified as a signal or causality. Tolokwani, do you want to go over that? Then we'll get another question. Then we'll go to Dr. Mwemba. He would like you to repeat. Unmute. Unmute.
Okay, sorry for that. I was saying this one refers to a vaccine now that is enough information around it. And we know that not necessarily vaccines, but medication in general has that untoward or undesired effect for some people. And then in turn, for vaccine, there is also that possibility that the unlikelihood that such and such event happens, these are the preceding maybe symptoms that is that I was making an example of the known side effect or adverse event that is related, major side event that is related to rota vaccine of intersusception in children. We know that if there is that condition in a child, there would be that projectile vomiters coming out, presenting with that child, and other accompanying symptoms that will actually make us now suspect that this might be happening. And those, we consider them as signals. Hence, it's a vaccine that is now well established, that has enough information around it to say, like for instance, there is this suspected association of blood clotting disorders for AstraZeneca, which is not necessarily been proven. It's still under intense investigation by all countries, I believe. And then once that is established to be true, and then signal or point us towards that event occurring, will be also articulated that if someone presents like this, this is what we need to be suspecting. It's signaling that a kind of condition. That is where AFI's grouped as signals are referred to. Thank you.
Thank you so much. I hope that is well understood. So for example, you have a vaccine or even a drug, then multiple sources of information are saying, we're observing this, we're observing this. It's not necessarily that it's confirmed, it just tells you maybe we need to look into it further. If you remember when Dolutegwa was released, there was some signal about maybe fetal defects. For now, there's still no causality, but it's something that's still being investigated because multiple people have reported this. It does not necessarily mean that it is the cause, but it has to be investigated to confirm if it is or not. So thank you very much, Tolly. Esther Chira, please go ahead with your question as Dr. Mwemba now starts his presentation. Esther Chira, please go ahead.
All right, thank you. I'm from Malawi, not necessarily a question, but you had asked on how many IF cases have been reported in Malawi. So we have received 125 reports, of which serious have been 12 and 4 have been investigated. So a total of around 307,000 people have been vaccinated since the initiation of the program.
Thank you very, very much. That data is very useful. So Malawi is standing at 125. Dr. Dien Mwanza, any data on Zambia? Esther, thank you very much for giving us context of which 12 have been serious. Dr. Dien Mwanza, I'm very happy.
Thank you. Thank you very much. Greetings. So for the case of Zambia, we've received a total of 48 reports. In those 48 reports, we have 55 events. And of those 55 events are split as 179 incidents. Of those 179 incidents, 98 had resolved. And by the way, this is the report from 48 hours ago, because in between we have not received any. So 98 had resolved, 50 were ongoing, and there were a few for which we did not have outcome information. So 48 reports, 55 events, and 179 incidents. Thank you.
Thank you very much, Dr. Mwansa. What do you mean when you say an incident and an event? Because you are using some new terms there.
So for a report is basically either a document coming through or a phone call coming through or an email coming through. So when I say 48, it's 48 of such interactions. For when I refer to events, I'm now talking about people. So how many people are involved? And then when I say incidents, I'm referring to the constituent experiences. Let me call them experiences. So for instance, a headache is an incident. But the reason we have more incidents is that one individual of those 55 may have reported 2 or 3 of these events. So somebody could have had headache, fever, and chills. So those, each of those is an incident, but there are 55 people involved and 48 reports. Maybe just again to give a little more context to that. So in the case of incidents, the headaches, we have 28 of them, fevers, 21 of them, injection site pain, 11 of them, dizziness, 9, chills, 8, arthralgia, fatigue, malaise, and pain, general pain and myalgia, all those 4, each of them has been reported 6 times. And then there are others that have even been reported like once. For instance, pruritus has been reported once. Someone has even reported severe hunger after getting the vaccine. Another person reported restlessness, so as one incident. So 48 reports, 55 people involved, 179 incidents. Thank you.
Very much, Dr. Dien. A lot of new terms there. We will follow you up on that. Maybe you can even present on that. Thank you. That's useful information. Dr. Mwemba.
Thank you so much, Dr. Sombo. Thank you so much, colleagues. It's time that we discussed vaccine-induced immune thrombotic thrombocytopenia, VITT. Next slide. So we'll look at VITT, we'll look at epidemiology, etiology, diagnosis, and then management. And then we'll go and outline other platelet disorders post-vaccination. So April 13th, US FDA and CDC suggested pausing administration of the J&J vaccine for investigations because of cases of severe thrombosis with thrombocytopenia. And at the same time, there were similar events in individuals receiving the AstraZeneca vaccine that we are using currently across Southern Africa. And the syndrome was termed vaccine-induced prothrombotic immune thrombocytopenia, VIPIT, or vaccine-induced immune thrombotic thrombocytopenia, VITT, whereas in the USA by the CDC and FDA, they termed it thrombosis with thrombocytopenia syndrome, TTS. So we'll go to poll question number 1, and the question reads, the following features make a diagnosis of VITT more likely except
A,
received certain COVID-19 vaccines less than 48 hours ago. B, thrombotic event. C, raised D dimer. And D, platelets less than 150,000.
so there we go. Let's give it a shot, very clinical. The following features make a diagnosis of VITT more likely, except A, received certain COVID-19 vaccine less than 48 hours ago. B, thrombotic event. C, a raised D dimer. D, platelets less than 150,000 per microliter. The following features make a diagnosis of vaccine-induced thrombotic thrombocytopenia more likely, except received certain COVID-19 vaccine less than 48 hours ago. B, a thrombotic event. C, raised D dimer. D, platelet more than 150,000 per microliter. We'll end the poll. That's the voting, Dr. Mwemba.
Thank you. So we'll answer that question probably as we go through the next slides. I'd love you to pay attention. So what is VITT or TTS? So it's a syndrome similar with what is called heparin-induced thrombocytopenia, and is characterized and must meet all the 4 criteria. So number 1, severe symptoms, and these symptoms should be lasting at least 4 to 30 days. 4 to 30 days, and should be post AstraZeneca or Johnson & Johnson vaccine. The peak usually is between 6 to 14 days. The peak is usually between 6 to 14 days. Number 2, there should be a venous. Venous is more common than arterial thrombosis in these cases. So venous is more common. And most of the times when we are asking, we might ask for a CT venous venogram or MRI venogram. Usually in unusual sites, cerebral sinus thrombosis or splanchnic thrombosis, the hepatic arteries and portal veins. So these are very unusual sites. Obviously, cerebral sinus venous thrombosis is more common than the splanchnic thrombosis. Number 3, they should have mild to severe thrombocytopenia, and the level of platelets should be less than 150 per microliter. Or if you have a baseline, there should be a decrease of more 50% or more. So the decline should be 50% or more if you have a baseline. But if you don't have a baseline, you can use the absolute count of less than 150,000 per microliter. 4, you should be able to do antibodies against platelets factor 4 in a heparin ELISA. So what we call HEAT ELISA, we use it for heparin-induced thrombocytopenia test. And this was first described in patients vaccinated 5 to 14 days with AstraZeneca vaccine. So the 4 criteria should be met for you before you diagnose VITT or what we call TTS. Next. The patients in Europe and UK reports primarily they were younger than 50 years of age, but they went up to the age went up to 77 years, and more than 2/3 were female, and none of them had received prior heparin. Remember that it's similar to heparin. Fewer had other risk factors for thrombosis, so no other risk factors commonly. Many patients were critically ill by the time of the thrombosis and thrombocytopenia were discovered, and up to 1/3 of them died. Other vaccines, so recently reported in patients receiving also J&J, and very similar to the AstraZeneca vaccine. And you know that both they utilize the recombinant adenovirus vectors, chimpanzee for AstraZeneca, and human for the J&J, encoding the SARS-CoV-2 spike protein for immunogen. So it seems that probably the adeno component might be activating antibodies against platelets, and that could be one explanation, but we are still not very sure about the pathogenesis. As of 23rd April, there was no patients receiving the Moderna or Pfizer vaccine had been reported to develop this. But recently, there's been reports of cerebrovenous sinus thrombosis in patients also receiving the Pfizer, and unabated few cases among the Moderna vaccine. So we're still learning, and probably this is something that we need all to learn. Next slide. What is the risk of cerebrovenous thrombosis or portal vein thrombosis when you receive a vaccine? So I will start with cerebrovenous thrombosis. So if you got COVID now, and 14 days from now, there's a chance of 42.8 per million chance that you're gonna get cerebrovenous thrombosis. Whereas that risk for AstraZeneca is 5 per million vaccinated. And for Johnson & Johnson is about 0.9 per million vaccinated. So you can see that when you compare with COVID and you compare with the vaccines, the risk is very low. The risk is very low. How about portal vein thrombosis? You can see again with COVID that you need for a million patients getting sick, you'll have events over 392, which is far much higher than actually even cerebrovenous thrombosis. But as I said earlier on, is that cerebral events for vaccines is higher than for portal vein thrombosis, and therefore the risk is even much higher, much lower when you compare the vaccine versus the COVID-19. What is the clinical presentation that should trigger to consideration of VITT or TSS? Severe recurrent persistent symptoms lasting 4 to 30 days post-vaccination. And these symptoms include neurological, intense headache, visual changes, change in mental status or seizures, signs of thrombosis or thrombocytopenia, abdominal pain, backache, nausea and vomiting, chest pains, breathlessness, leg pain or swelling, bleeding or petechiae. Please note that constitutional symptoms like fever, fatigue, headache, muscle aches, common between the first 24 hours to 48 hours post-vaccination are not suggestive of VITT. So within the first 24 hours to 48 hours, those symptoms that commonly occur, you should not relate them to VITT or TSS. Poll question number 2. In a person with suspected VITT, the following tests should be ordered where available. A, full blood count. B, SARS-CoV-2 PCR. C, imaging for thrombosis. And D, PF4 heparin ELISA.
Okay. So please, let's go ahead and vote. You will note a modification to the question. In a person with suspected VITT, the following test should be ordered where available. Is it a full blood count, a SARS-CoV-2 PCR, imaging for thrombosis, a platelet factor 4 heparin ELISA, or the above, none of the above? To give people a chance to vote. In a person with suspected vaccine-induced thrombocytopenia, the following tests should be ordered where available. A full blood count, a SARS-CoV-2 PCR, imaging for thrombosis, platelet factor 4 heparin ELISA, all the above or none of the above. This is an interesting one.
So there's an E and F
E and F
option
has
there.
been added.
Oh,
Leakage.
Okay, so the doctors here also have given their answer. We'll share later. Okay, so this is the voting pattern. Some people felt a full blood count. Some people felt a SARS-CoV-2 PCR, imaging for thrombosis, platelet factor 4 heparin ELISA. And some people felt all the above will actually be necessary. For the team here, the people from our OPD felt that it's, they also voted on, is that E? Yes.
Yeah. So I guess that will answer that question on this slide. What is an appropriate initial workup for these patients? So a full blood count and a peripheral smear. So platelet less than 150,000, you're looking for that, or a decrease of 50% or more. Then 2, imaging for thrombosis. That's either a CT-V or MRI-V. And you're looking for cerebral sinus venous thrombosis or splanchnic thrombosis or pulmonary embolism or DVT. D-dimer, the majority of patients have markedly elevated D-dimers. Fibrinogen, usually low. PF4 heparin ELISA, nearly 100% of cases reported have had positive S's. So this is from the South African Medical Journal, and this is what is being used to score patients that are, to see whether they have a probability of a VITT. And you can see that the score has thrombocytopenia there. It has the timing of the event, it has thrombosis, and then it has other causes of thrombocytopenia. And depending on the score can be graded between 0 to 3 or 4 to 5 and 6 to 8. And between 4 to 8 is either intermediate or high score. And an intermediate or high score is indicative of VITT. We were just discussing the other time that maybe in the countries like us, we might need to just modify this score and bring it down to 4, and probably something that we can use and be able to score a patient when they come and see whether that they fit into the score of 4, and then we make a decision. So we'll go to management. So management is that because there are antibodies there, you need to block those antibodies, and so you give IVIG 1 gram per kg daily for 2 days. You use non-heparin anticoagulation. As you can see that the pathogenesis seems to be similar to heparin-induced, and therefore here you have to avoid. You can either give the parenteral or direct thrombin inhibitors, and they are mentioned there, or you can give the direct oral anticoagulants without a lead-in heparin phase. And we have options there. Obviously for Zambia, I think our main option is dabigatran. The experience with most of these is rivaroxaban, but I guess for Zambia, it will be much of dabigatran. Suggests avoidance of non-fractionated or low molecular weight heparin because it might worsen the thrombocytopenia. Plasma exchange at the moment, not recommended unless the patient shows continued thrombosis despite IVIG or non-heparin anticoagulation, because usually it's believed that these IgG are well distributed across the body, and so to remove them might be an issue. And the risk of bleeding because of catheters that you have to put either in the veins, and therefore it's a last recommendation that you want to do. Next. For patients that have a low fibrinogen or bleeding, which are associated with VITT, it should not be absolutely preclude anticoagulation, especially when the platelets are above 20,000. So it doesn't mean that when you have low fibrinogen or patient is bleeding, then you avoid anticoagulation. You can give the anticoagulation as guided with IVIG. You can also probably replace with fibrinogen. I think most of our blood bank here, we can still ask for fibrinogen in patients who are bleeding and they got very low values. Fibrinogen should be considered. Like in heat, you avoid platelet transfusion. Corticosteroids have been administered along with IVIG in some cases and with no consensus at the moment, but some of the review cases that have been reviewing, actually corticosteroids have been used. Avoid aspirin. I've had questions where people want to take aspirin. Avoid aspirin either as treatment or prophylaxis. First of all, it's not efficacious in preventing heat antibodies. So you want to prevent the heat antibodies and may increase the risk of bleeding. Next. So this is just gotten from the New England Journal, published, and I think this was from Norway, 5 patients from Norway, just trying to show you that when you initiate immunoglobulins down here, you can see how each of these patients, the platelets were increasing. Those patients that failed to increase the platelets, there were mortalities. Next. We'll discuss then the other post-vaccine platelet disorders that can happen. POC question number 3. State whether the following statement is true or false. All platelet disorders after vaccination are associated with thrombosis. True or false?
It's a very good one, Dr. Mwemba. All platelet disorders after vaccination are associated with thrombosis. Is this a true or false statement? Apologies, I have to relaunch that. State whether the following statement is true or false. All platelet disorders after vaccination are associated with thrombosis. Is this true or false? Yeah, if you voted before, I had to relaunch. Please vote again. We lost your exam paper. You need to write again. State whether the following statement is true or false. All platelet disorders after vaccination are associated with thrombosis. Is this true or false? So we'll end the poll. Just share how we voted. So 82% felt that it's not true. Some can just be platelet thrombocytopenia alone, while 18% felt that it's actually true.
Thank you. So there's what is called new onset acute immune thrombocytopenic purpura, ITP, and 100 cases of acute ITP have been noted for AstraZeneca, J&J, Moderna, and Pfizer. So there's some ITP or thrombocytopenia that can just occur to all these vaccines. And the median time is 8 days, and platelet count usually less than 10,000. Bleeding is common and without thrombosis. So a patient can come with bleeding with a low platelet and no thrombosis. And very few cases are positive for P4 ELISA. The estimate is that this is very rare, 1 in 100,000 to a 1 in a million vaccination. So we don't know whether this is true due to vaccination or it's just in a coincidental event. And it is important that we start looking for it. The good part is that the treatment seems to be almost the same like VITT. And so you give IVIG and or steroids. So if you don't have IVIG, you can start steroids. You can consider platelet transfusion if they are bleeding. Only when they're bleeding, then consider platelet transfusion. thrombopoietin agents or possibly a single dose of vincristine might be useful if there's no immediate response to IVIG or steroids. Next. There are patients with existing thrombocytopenia that have no thrombosis. Patients usually, again, the period is about 5 to 30 days, so similar to VITT, and usually as a result of AstraZeneca and J&J vaccine with thrombocytopenia, they will have an elevated D-dimer without other clear cause. So what I'm trying to say here is that you might have thrombocytopenia, no thrombosis, secondary to the AstraZeneca vaccine or J&J vaccine with elevated D-dimer and without thrombosis, and that could be a post-vaccination thrombocytopenia. So even in the absence of documented thrombosis or suggestive symptoms, they should be treated with IVIG. Close monitoring is important, very low threshold for initiating non-heparin anticoagulation. Based on high rising D-dimer, you might start the non-heparin anticoagulation. A recent report documented rapid improvement in laboratory parameters in such patients with both IgG and non-heparin anticoagulation without progression thrombosis. So it seems like maybe some of them, we might be preventing them from having thrombosis. Next slide. So there are patients with pre-existing ITP. Sorry for that typo there, it's supposed to be ITP. So there are patients that you're following up in the clinic and they have existing ITP or other causes of thrombocytopenia. Remember, when you give them the vaccine, there's a chance that that platelet level might go down a bit. And at the moment, we do not know what to do, but it's prudent that probably we screen them with an ELISA, just to be clear whether the decline in platelets occurring during the relevant frame time and should be treated. This is just an algorithm, which I'm not going to go through, of how you need to go through, and we'll send the slides that you can check how you make diagnosis and treatment decisions. Next. So I'll go to the summary of key points. So diagnosis of VITT must have all 4 criteria. COVID vaccine, either secondary to J&J and AZ, and probably very soon we might include the other vaccines. 4 to 30 days previously. There should be venous more common than arterial thrombosis. There should be thrombocytopenia, and you should have a positive F4 hit ELISA. Incidence is extremely rare, as I've showed you. And so the benefit of vaccine outweighs the risk of thrombosis. So you are more likely to have, when you have COVID, to have a thrombosis than when you get the vaccine. Agent medical evaluation is indicated if any of the following symptoms develop between day 4 and day 30, and I'm not going to go through those symptoms because we've already gone through them. Initiate treatment with IVIG and non-heparin anticoagulation pending your P4 ELISA results. So do not, once you have one of those, do not wait for your PF4 result. Once there are signs and symptoms of serious thrombosis, or at least one of the following, positive imaging or low platelets or both, you need to start. Or you have no signs or symptoms of imaging documenting thrombosis. So no thrombosis at all, but they have low platelets and very high rising D-dimer or a positive PF4 ELISA, you need to start. So what am I emphasizing here is that you need to have this combination of symptoms, either with or without thrombosis, and you have to decide to give IVIG and non-heparin anticoagulation. If thrombocytopenia but no thrombosis and negative on P4 ELISA, it is likely that we might be dealing with a post-acute ITP post-vaccination. And again, you might have to give IVIG plus steroids. Avoid platelet transfusion unless other treatments have been initiated or there's life-threatening bleeding or imminent surgery. That's when you can consider that. Consider referral to a tertiary care center if you think that the likelihood of VITT is very high. Next. So those are the references. I think some of them are below those, the slides, and then you can just go through and you get them. Next. So we'll go to the poll questions again and see whether we have learned something.
So let's give this a go again, as Dr. Mwemba explained. The following features make a diagnosis of vaccine-induced thrombotic thrombocytopenia more likely, except A, received
You
certain
can see it
COVID.
there.
You can see it?
I can see.
Oh, you can't. You have to use my screen, sorry. Oh, I will bring it up
Okay.
as the answer.
Okay, no. I put 2 slides.
Yeah. The following features make a diagnosis of VIT more likely, except they received the vaccine less than 48 hours ago. B, a thrombotic event. C, a raised D dimer. D, platelets less than 150,000. Remember that this is, we'll end the poll so that we don't change our minds. Okay.
Yeah, so that's the answer. Remember, we emphasize that symptomatology should be between the 4 to the 30, and therefore within 48 hours is probably the common events that you expect, and therefore those should not be considered as part of the VITT diagnosis.
Thank you very much, Dr. Mwemba. Before we go to the next poll question, I want to check with Team Mozambique. Has Alejandros Bustos joined us? He did submit some very nice addendums to these slides. He said these are wonderful slides, just to add a few things. Alejandros, are you able to talk about your addendums where you talked about the need for contrast if you are checking for a thrombus? Alejandros? Okay, so I think he just mentioned that if you're going to look for a thrombus, please remember to use contrast. Of course, make sure that the creatinine is not abnormal. That's the caveat. And he also mentioned about the fibrinogen needing to being above 150, and that the D dimer is very raised, and usually it's more than 4 times the baseline. That's pretty high. So thank you, Alejandros, for those additions. We'll go to our next poll question.
So most of the people got this one correct, right?
Yes, they did well. Thank you. Okay. In a person with suspected vaccine-induced thrombotic thrombocytopenia, the following tests should be ordered where available: a full blood count, a SARS-CoV-2 PCR, imaging for thrombosis, platelet factor 4 heparin ELISA, the HIT, all of the above, none of the above.
So thank you. Seems like 91% of people got it right. So it's all of the above. Why have we included SARS? Because as I've shown in the slides that COVID-19 itself has a high chance of giving you a thrombosis. And therefore it is important, even when someone comes after 4 to 30 days post-vaccination, that you confirm that they don't have COVID-19. And so you can do a rapid antigen test, but you can also do a SARS-CoV-2 PCR just to make sure that they do not have the COVID. And secondly, they don't have been infected after being vaccinated.
Thank you very much, Dr. Mwemba. Just to give that context, just yesterday, Dr. Bwalia, I don't know if you can summarize your case of the patient who had the DVT, 17 days post-vaccine. You don't have to stand yet.
Good afternoon, everyone. So to talk about the case that we had yesterday, we had a female 38 who's got vaccinated 17 days ago, and she started to present with, on initial day after vaccination, she had the usual fever, chills, which went off after day 1. Then on day 15, she started noticing swelling and pain of the left lower limb, which extended from the toes up to upper thigh. And she has no comorbidities. So yeah, but she is obese, of which a BMI was 30.1 after measuring. And the other examination, she was stable. And on the gynecological history, she's a nulliparous woman who's been married and not conceived before. She's been on some fertility pills and clomiphene citrate to help conceive, of which 7 years ago, she also had a history of myomectomy, of which she also has amenorrhea, could have had also suspecting a polycystic ovarian syndrome, or she could be having recurrent fibroid uterus. So on the examination again, she was stable, then chest CVS and the abdomen were unremarkable. Then on the lower limb examination, which was a local exam, she had an obvious swollen left lower limb, which was obviously noted, and there was on the left side, which was the skin was very shiny and warm to touch. And the peripheral pulse was palpable, the dorsalis pedis. So afterwards, we went on to investigate her, which we did a full blood count, which was a platelet was one.
She had a thrombocytosis.
Yeah, she had a thrombocytosis. Then also on hemogram, she had anemia, microcytic hypochromic. Yeah.
The normal D-dimer.
Normal D-dimer.
She had a very big DVT. In summary, this is a lady that had a lot of comorbidities and risk factors for DVT. So we are getting a lot of referrals, and we are just concluding that one, the golden egg, we already have it. It is all in the history. All the people we've checked, we've turned out to have either have risk factors, or you ask them to give you an old platelet, you find that that platelet was actually low before. So we are getting a very interesting cluster of cases. And what is of note is that this lady had actually traveled from another province where she was taking care of a patient with COVID-19. So that's how we're like, oh, even the SARS-CoV-2 PCR is actually something to consider. Yeah, so well done, Wadia.
So we tested her yesterday for the COVID, which PCR is still pending, and the rapid test was negative. Actually negative. Thank you.
So I think just to emphasize that as they come, just make sure that
your history,
you rule out, the history is very good, and just rule out also COVID itself.
Yeah, so we are getting a lot of flags, I think, because we also got the vaccine at the time when the signal had been raised. Yeah. So we are seeing a lot of patients, but actually we have not had a confirmed case of it.
No. So poll question, the last one, number 3. State whether the following statement is true or false. All platelet disorders after vaccination are associated with thrombosis. All platelets disorders after vaccination are associated with thrombosis. True or false?
Okay, that's you. Wow.
Wow. So 96% got it right. As we have just discussed, that an individual can have thrombocytopenia happening actually even before you have thrombosis, one, and you need to have just your D-dimer going up, and then you can make a decision. Secondly, that you can have people who have acute ITP developing after 4 to 30 days post-vaccination, and also they need to be treated with IVIG plus steroids, pending decision whether you need to non-heparin anticoagulation. And then you can have people with existing thrombocytopenia as well that can have their platelets going down post-vaccination, and you just need to monitor them and make a decision whether they need to be treated as well. So thank you so much. We'll wait for questions and comments.
Thank you so much, Dr. Mwemba. That was brilliant. And the two presentations really complemented each other. First, we learned that these are adverse events of special interest. So these VITs, the reduced platelets, but even more importantly, is that this signal has been raised even for the non-adenovirus vaccines. First, the signal was in the AZ, the AstraZeneca, then J&J raised the signal, then now we are hearing Moderna has, Pfizer has, so this is very interesting. But overall, the risk still remains very small. Dr. Staluchanda, please go ahead with your question. Dr. Staluchanda, please go ahead.
Why put me like that?
Thank you, Dr. Faloshi, and Dr. Mwemba, thank you for the presentation and the guidance. Just wanted to ask Dr. Mwemba to highlight further on the use of, I know you mentioned that we need to avoid using heparin-based anticoagulation. And the guidance is that we use direct oral acting anticoagulants such as rivaroxaban as well as dabigatran. What's the guidance on the use of warfarin for anticoagulation in these patients? Thank you.
A great question, Dr. Stalu, because the DOACs, the newer oral anticoagulants are actually pretty expensive.
Yeah.
So I haven't really seen any data, but I don't think there's any contraindication per se.
There's no straight contraindication, but the literature that I've reviewed, the mechanisms, all of them seem to suggest that you wait until the acute phase of the platelets, until the platelets have recovered. Then that's when you can introduce warfarin. I didn't understand the reason why, but that's the guidance at the moment.
I think that's a very important question because we are actually resource constrained and most of these are expensive. But there's a very good question that I saw. I seem to have lost it on the cost and where we are doing the HIT, the IgG, the PF4 test. I think the question was, how much is it? How accessible? Okay. Titi Chatora, are you able to unmute your microphone? Titi?
Hello.
Yes, Titi, please go ahead.
Okay, thank you so much for a wonderful presentation. So I think my question was just from the perspective of a low resource setting, just to get some understanding around accessibility as well as perhaps a cost of introducing this test. I do appreciate though, because it's a very rare side effect, but just I think it would be good to have such information if you may have. Thank you.
So, so I do not have information on the actual cost. Actually, even the US itself is that they do not have capabilities to do PF for ELISA. And so they're trying to put in mechanisms so that it can be widespread. Even back here in Zambia, we do not have that capability. And yesterday we were struggling on where to send the sample, and we've sent it to India. I'm not sure how much that would cost us. But obviously, I think that the beauty about it is that the decision can be made before we are waiting. You can see that in the guidelines says that you can make a decision based on the symptomatology and your platelet level while you're waiting for the result to come out. So, for example, if a patient has a stroke, or you do a CT and literally they have thrombosis in there, and the platelet is low, do not wait for the PF4 to come back. You need to make a decision and treat. You have a patient who has some symptoms of some kind and they don't have thrombosis, but they have platelets that has been dropping and they've received the vaccine in the last 30 days. There's no need for you to wait for the results. You need to initiate treatment because early treatment seems to save lives. So that would be my guidance at the moment. And hopefully that obviously as we go forward is that the test will come available and it will be cheaper.
Thank you very much, Dr. Mwemba. I think even more importantly is the availability of IVIG, because this seems to be the backbone even before you get to the anticoagulants. So IVIG is actually quite expensive as well. And I see Titi mentioned that anything for resource-constrained countries, I think SARE gives us an opportunity to create our own databases and explore this. I said we've encountered a lot of them in the short time, but most of them actually have just turned out to be something else. Yeah. So I think as resource-limited countries, you can strengthen on things like your history taking. For us, we are working with our hematologists and the team of doctors. They are actually not specialists. They are just they are post-internship. So they see when we get these with this IASI, because we know that it's actually difficult to treat, it's expensive. So all these are seen by them, then we speak with the hematologist. So that's important.
And just to make a last call, whatever, is that I hope that obviously as we moving forward, is that steroids will be very useful. I see that in a number of cases, for example, 5 of the cases that were in Norway, all of them steroids were used in combination with the IVIG. So I'm hoping that as we move forward, steroids will become more available and they will be approved for initial use.
Yes, even more importantly, we hope we don't see these cases in Zambia or elsewhere. Dr. Jonas Hines just wants to comment that yes, the risk is small, but what's also important is that it just shows that we are paying attention to safety and adverse events. So we need to know that. Dr. Kowa, please go ahead with your contribution.
Thank you very much for the presentation. Wonderful indeed. So with this knowledge of VITT, I just wanted to know for hematological patients with myeloproliferative disorders, essential thrombocythemia, polycythemia vera, or other risk factors like your antithrombin deficiencies, protein C, protein S, would it be advisable for such patients to go ahead and receive the vaccine? Are there any advisories to that effect? Thank you.
Obviously, you've asked me, but I thought that probably that should be answered by you.
Yes,
but at the same time, I'll try to answer. So the literature that I reviewed, I think that no specifics were mentioned. But what I remember is that I think some of the patients that had ITP or other conditions, and I'm hoping that those other conditions included some of the pathologies that you have listed, is that all the advice was that they need to be monitored because there's a chance that the platelets can slightly go down, but not markedly. And so what I got from that is that probably they can be given. But I think that the advice is that those patients should first see the hematologist, who should advise whether they can go ahead and get the J&J and AstraZeneca vaccination.
Yeah, for sure. They definitely have to see their doctors, because I know that one of the patients with polycythemia vera called and said, can they get the vaccine? I did advise that they need to go back to the doctor and we do tests, because we know polycythemia with time, you may find that your platelets have dropped and you haven't done it. So I would propose they do a full evaluation then, because with these disorders, they can either progress and things like that. Katie, I know you have a question. Do you want to unmute your microphone and ask it? Katie Simon? So Katie was asking, is there evidence to show that there's an increased risk of VIT on the second dose as opposed to the first dose? Did we have that type of data? So
unfortunately, I didn't look at that data. So unless someone else has looked at that data, but I think that most of the cases were reported from the first doses. So sorry, Katie, I can't answer that question for you. I didn't look at that data.
I haven't seen such data yet, but I guess this may be thinking about if you get a first vaccine and you're a bit sick, you tend to be sicker on your next one. So this is something to think about. Professor Lloyd, I'll allow you to ask the last question.
It's not a question, it's just a comment. There are certain guidelines which have included warfarin for VITT. So it's something which can be considered, but again, because of the various interactions, drug-to-drug interactions, and also the monitoring aspect of INRs, that also brings in a challenge. Then over the question regarding the frequency, is it higher after the second dose? No, what has been reported is after the first dose. As you have seen, most of the instances, you see them from the 4 up to the 20, though it can go to the 30. And by the time that you're giving the second dose, it's usually most of them, it's 3 weeks. And others where we're giving for 10, 8 to 12 weeks. So it's likely mostly associated with the first dose. And this is an immune based reaction. So you'd expect it just immediately after the immune development or reactions start kicking in. It's different from the other side effects which you see, like the fatigue, the fevers, the myalgias. You see them more after the second dose. Most of the reports, they are higher after the second dose, but this has largely been reported after the first dose. Thank you.
Professor Lloyd, thank you very much. At this point, we need to close. We've really overrun this session, very interesting. We want to thank Team Eswatini for their presentation on IAFIS and letting us know about adverse events of special interest, which Dr. Mwemba presented about, usually the platelet disorders and the clots and the VITT. We thank you all. Please remember to share your feedback. There's something that's been posted in the chat box. Special thanks to our doctors that are responding to all these here at UTH. Thank you all for joining us. We'll see you after 2 weeks and we will communicate the topic. Thank you.